Hi, my name is Connie Koklanis and you're watching the video Hess and Lee Screen Interpretation of Hess Charts. The Hess chart is utilised to record the findings from both the Hess screen and the Lee screen test. So in discussing the interpretation of the Hess chart, we're discussing how to interpret the findings from either of these investigations. Okay, when interpreting Hess charts, it's important that we consider three things: the position of the Hess chart, the size of the Hess chart, and the shape of the Hess chart. I'll take you through each of these components in a moment, but before we do that, I would like to revisit the recording sheet and take you through this one more time. So you'll remember that this field here represents the right eye, as indicated on the recording sheet, and this field here represents the left eye. You'll also see that there's recordings of extraocular muscles on the Hess chart. Here we see medial rectus, inferior oblique, superior oblique as an example. This indicates that when you assess the left eye and are looking at this point here, that you're assessing the medial rectus, or at least the left eye in right gaze. It's also important to remember that each square represents 5 degrees. And this is, of course, assuming that you perform the test at 50 centimetres, which is what you should be doing. Now, the Lee screen, because it has a chin rest, is always at 50 centimetres, but with the Hess screen, if you don't have a chin rest, you'll have to ensure that you have your patient 50 centimetres away from the chart. Let's commence with position. As I've already indicated, the left field represents the left eye, the right field represents the right eye. The next point to make is that the position of the central point indicates the deviation in primary position. So if we take a look here at primary position, the patient has indicated that this is where their eye is. So we have an exo deviation and a hypo deviation. And because, as I indicated earlier, each square indicates 5 degrees, we can actually measure out how far out it is. That's 5, 10, 15 degrees out, and just less than 5 degrees down. If we move over to the left eye, this is where our primary position was, and this is where the deviation is in primary position. So we have an exo, and the eye is slightly up. We can measure it again, 5, 10, 15, maybe about 17 degrees out, and approximately 5 degrees up. In relation to the laws of innervation, what we see here is what we expect. So when the patient is fixing with the left eye, the right eye is out and down. When the patient is fixing with the right eye, the left eye is out and up. Another point to make is, which you may have noticed already, is that the position of the field reflects the position of the eyes. So if we look at the right eye, that right field is out and down. And when we looked at that primary position, what did we notice? It was out and down. Okay, and if we look at the left eye, the field is out and up. And again, that's representative of the position of the eye. And the reason that the position of the field reflects the position of the eyes is because the Lee screen and the Hess screen test rely on foveal projection. Moving on to size now, we want to have a look at the relative sizes of the two fields, and we want to determine which is the smaller of the two fields. What we can see here is clearly that the right field is smaller than the left field. Now, you'll notice that for the right eye, the inner field has been plotted and the outer field has been plotted, but for the left eye, only the inner field has been plotted. And this is because the inner field is so large that the orthoptist has not plotted the outer field, as it's probably going to come off the chart. Now, when we determine which is the smaller field, we've actually found the field that belongs to the affected eye. So the affected eye in this particular instance is the right eye. And this will thereby be the eye with a primary limitation of movement. Now, looking for underactions and overactions, we'll start with underactions. What we're looking for here is the displacement of the field interior to the normal field. So as an example, let's look at the left eye. And what we can see here is this is the point that's representative of the superior oblique, and the field is actually interior to that normal position. That's an underaction. And here we see again, this is the position of the superior oblique, and we can see that the field is interior to that normal field. Now, in neurogenic palsies, we're expecting a muscle sequelae. So the next thing to do is to look for this muscle sequelae, and the other underaction that will occur in the muscle sequelae is the underaction of the contralateral antagonist. So if we come and have a look at the contralateral antagonist, which is over here, the superior rectus of the right eye, we see that this is not interior to the normal field, it's just out, really, and so there really isn't an underaction at this point. As you will recall, the muscle sequelae can take some time to form, and when a patient recently acquires a neurogenic palsy, often the only component that you'll see is the overaction of the contralateral synergist. The next component to develop is the overaction of the ipsilateral antagonist, and the last component is the underaction of the secondary inhibition of the contralateral antagonist. So it's not uncommon to not see the complete muscle sequelae. This indeed might be indicating that for this patient, this is a recently acquired neurogenic palsy rather than a long-standing palsy. We'll talk more about differentiating between long-standing palsies and recently acquired palsies at a later stage. Now, with overactions, we'll of course be looking for the opposite. We'll be looking for the displacement of the field exterior to the normal field. So if we have a look at this example, here is the inferior rectus, and what we see is an overaction with the patient's field being exterior to this normal position. In the outer field, we see these arrows. These indicate that the patient placed the light at a point outside of the actual chart. So it's a large overaction when you see arrows. Another point to make is that the outer field should be examined where there are small underactions or overactions. In this instance, we have both the inner and the outer field plotted, but you can actually see that if you look at the left eye, the underaction noted on the inner field is much smaller than the underaction noted in the outer field. And you can see here that the deviation is 5 degrees in the inner field. And then when you've taken the patient out into 15 degrees, you've got 5, 10, 15 degrees. So the more you move the patient into the field of action of the affected muscle, the greater the deviation will get. And this is why I've mentioned in previous videos that it's important to measure the outer field if you have subtle underactions or limitations. You may not pick them up in 15 degrees, but you may pick them up in 30 degrees. Another thing to note about size is when you're struggling to work out which field is larger or smaller than the other, you're starting to look at concombitancy. When you have a small field and a large field, what you've got is incombitancy. So the opposite of that is when the fields start to look very similar, you've got concombitancy. This happens with long-standing palsies. With time, the muscle sequelae will decrease and the deviations between the eyes will become very similar. And below here, we have an example of a patient who is developing or has developed concombitancy. Let me show you how we can see concombitancy. Firstly, it's actually difficult to tell which is the smaller field between the two eyes. Secondly, if you start to look at the deviation in various positions, you notice that there isn't much difference. If we look at the right eye, we can see that the right eye is 5 degrees down in primary position. If you look at them over here in left gaze, it's 5 degrees down as well. If you look at them over here in right gaze, it's 5 degrees down. So there's no difference between lateral gaze, and even if you look up, it's 5 degrees down here, it's 5 degrees down here, and etc., etc. So there's very little difference, or no difference really, between the 9 positions of gaze. And when they're fixing with their right eye, there's very little difference again. It's 5 degrees here, it's 5 degrees here, it's 5 degrees here, or we have 5 degrees of hyperdeviation when the right eye is fixing. So this is why there's not much difference in the fields between the right and left eye, because the patient has reached relative concombitancy. So in this particular example, as compared to a previous example, this field might suggest that the patient has had this deviation for quite some time. Another thing to look for is if there's any narrowing of the fields. When you have narrowing of the fields or restriction in opposing directions, this is an indication that you have a mechanical restriction. So if we take this example, what we can see if we look at the left eye is that we have limitation of elevation. Limitation here in lateral elevation, limitation here in direct elevation, limitation here in dextral elevation. And recall in the video on ocular movements, I mentioned that when you have a range of positions that are limited, this is more indicative of a limitation that's mechanical. Okay, not only that, but you actually have a limitation in opposing directions in this instance. So what we have here is a limitation also of lavodepression and of direct depression and a slight amount over in dextro depression. Now, this limitation in opposing direction is what causes the narrowing, and it's not what we see in neurogenic palsies. In neurogenic palsies, if we had an underaction of the inferior rectus, we'd expect an overaction of the superior rectus. So we don't see restrictions in opposing directions. This is a mechanical restriction. And so what we're seeing here in this example is clearly not a neurogenic palsy. It does not follow the muscle sequelae that we see in neurogenic palsies, but rather what we have is a narrowing of the fields, we have restrictions in opposing directions, and what we're seeing is a mechanical restriction. Lastly, we'll look at the shape of the Hess charts. And what we're looking for in relation to shape is tilting or sloping of the fields. And you can see here that the fields, if we take that inner line, we can see that they're starting to slope. What this indicates is whether you have an A or V pattern. Be very mindful that it does not represent torsion. It represents whether an A or V pattern is present. Now remember, AV patterns are a result of a change in the horizontal deviation between up and down gaze. When assessing the AV pattern, it's best to do so utilising the outer 30-degree field, but I'll just use the 15 or the inner 15 degrees as a starting point. And what we see here is in depression, we have an exodeviation, and let's measure that. It's 5, 10, 15, 20 degrees exo in down gaze. Now let's have a look at up gaze, and we have a 5, 10, maybe a little bit, maybe about 12 degrees. Okay, so in this instance, we've got a 25-degree exo in down gaze, a 12-degree exo in up gaze, and so we have greater than 10 diopters worth of difference between up and down gaze. Now this is also seen in the outer field, but you see the outer field hasn't been completely measured because it's coming off scale, but this is actually the point at which the deviation is in 30 degrees, and you can measure it and you'll see that you've got a 5, 10, 15, 20 degrees exo up here, and here we've got a 5, 10, 15, 20, 25, 30 degree exo deviation in this position. So we can see that this patient clearly has an A pattern to their deviation. Let's do one example of looking at the position, size and shape of the fields. I'm going to start off with size, and let's determine which of the two eyes has the smaller field and thereby determine which of the two eyes is the affected eye. And so if you have a look here, it's clear that the right eye is smaller, and so the right eye is the affected eye. Now in terms of position, we can see if we look at the prime position that we have an ESO deviation when looking at the right eye and fixing with the left. And here we also have an ESO deviation when the patient is fixing with the right. What we see is that the deviation of the right eye is 5 degrees, but when the patient fixes with the right eye, the deviation is 5, 10 degrees. I'll talk to you more about why this is the case in a subsequent video, about why it is that when the patient fixes with one eye, they have a greater deviation as compared to the other. But at this point, it's sufficient to understand that the smaller field belongs to the affected eye. So looking at shape, we see no AV patterns here. But now let's also look for any underactions and overactions. Now we can clearly see here that the lateral rectus is underacting. The superior rectus is not underacting, nor is the inferior rectus. However, what we're seeing is simply that because the patient can't abduct, we're unable to get the eye out into this position to look at the superior rectus. And again here, because the patient is struggling to abduct, we can't get the patient into the position of the inferior rectus to have a look at the inferior rectus. The fact that we also don't see any height on this Hess chart is indicating that we don't have a vertical muscle issue. If we move over to the other eye, we can clearly see that we've got a medial rectus overaction. Okay, these arrows on the outer field are showing a large medial rectus overaction. And we can also see it here on the inner field, that medial rectus is overacting. This follows the muscle sequelae, where the left medial rectus is the contralateral synergist of the right lateral rectus. In relation to looking for the other components of the muscle sequelae, we can see there's really not much in what's happening to the medial rectus of the right eye or the lateral rectus of the left eye. And so again, the fact that we're only seeing two elements of the muscle sequelae might be indicating that this is a recently acquired neurogenic palsy. Now, we don't have constriction of fields, we don't have limitations in opposing directions, we have what seems to be consistent with a muscle sequelae, and therefore what we have here is likely to be neurogenic rather than mechanical. Indeed, what we actually have here is a right lateral rectus palsy, or a right sixth nerve palsy, and we arrive obviously to the sixth nerve palsy because the sixth nerve supplies the lateral rectus, and it is a recently acquired sixth nerve palsy. It's important to note at this point that you don't make a diagnosis solely on the Hess chart. The Hess chart assists you in making a diagnosis, but you will integrate your clinical findings to come to a final diagnosis. In summary, there are a couple of golden rules to interpreting Hess charts. Firstly, the smallest field belongs to the primarily affected eye. Secondly, look for the development of muscle sequelae, and remember that you may not see all components of the muscle sequelae. In recently acquired neurogenic palsies, often you'll see the primary limitation and then the contralateral synergist overacting. Look at the sizes of the fields as an indication of whether the deviation is recent or long-standing. The more similar they are in size, the more likely it's a long-standing deviation. Or perhaps it's non-paralytic. So as an example, if you plotted the ocular movements of a patient with a non-accommodative esotropia, what you would find is essentially a concomitant deviation, because the patient doesn't have a neurogenic palsy. They have a concomitant strabismus, and the Hess chart will show you this. If you have any narrowing fields and limitations in opposing directions, this is an indication that you have a mechanical restriction. So where you don't have a deviation that is following the sequelae of a neurogenic palsy, you have a mechanical restriction. And finally, remember, sloping fields are an indication of AV patterns and do not represent torsion. Before I conclude this video, let's come back to our case study, Miss Jones. She actually had the Hess screen test performed on her, and this was the result. Now what we can see here is that the right eye is up, so we have a hyper deviation. The left eye is down, or it has a hypo deviation when the patient's fixing with the right eye. And comparatively speaking, the right eye, or the field of the right eye, seems to be slightly smaller. So this may be the primarily affected eye. And here we should find the primarily underacting muscle, and what it appears to be here is the superior oblique seems to be underacting. Okay, in terms of looking, we might now look for the muscle sequelae and have a look to see whether we're seeing any overactions or underactions that are consistent with a neurogenic palsy. So let's start off with a contralateral synergist. So if we move over here, there does appear to be an overaction of the inferior rectus of the left eye. If we look for secondary inhibition of the contralateral antagonist, we're really not seeing all that much here. And in terms of the ipsilateral antagonist, it's not particularly obvious that we have an overaction here. This is where it's important that we actually probably do that 30-degree outer field, because the over and under actions are relatively subtle and we're not picking them up very easily on this inner field. So let's compare this actually to the orthoptist recording of ocular movements. And this was the recording for ocular movements. They noted a right superior oblique -1 and a right inferior oblique 2+. Now we really didn't see that 2+ right inferior oblique overaction, and what we really need to do is have a look at that patient in that 30-degree outer field to see if it would be noted in that particular position. The orthoptist has made no comment of the inferior rectus overaction that we have seen on the Hess chart, and the orthoptist has indicated that there's a V pattern, which is not very obvious on this inner field either. So what we can see, if we take the horizontal deviation here, the patient has no horizontal deviation in direct elevation, and then there's a slight ESO by about less than 5 degrees, which is not a difference of greater than 15 prism diopters. Okay, so again, if we assess the patient in the 30-degree outer field, in this instance we may have found that they do actually have a V pattern. Now, just utilising the principles we've learnt about distinguishing between a mechanical and a neurogenic palsy, we see here that there's no narrowing of the fields. We see that we don't have limitations in opposing directions. So the Hess chart looks more neurogenic in nature than it does mechanical. We're also seeing elements of the muscle sequelae, which again lean us towards a neurogenic palsy. Okay, so that brings us to the conclusion of this video. Thank you for watching.